I'm Amandeep Arora. I'm a fellow in neurology at Tata Memorial Hospital, and I'll be presenting my protocol on a dose de-escalation study to determine the lowest effective dose of intravesical BCG that is used for Indian patients with the Moscow strain for patients who have non-muscle invasive bladder cancer. So, just to the background about BCG in NMIBC, that is non-muscle invasive bladder cancer, it was described in 1976, FDA approved in 1990 of top cities. And the currently used schedule of installation was determined by the Southwest Oncology Group in 2000. In India, the first report came from Tata Memorial Hospital in 1994, and there is no doubt about the oncological efficacy of BCG. It is proven benefit across multiple studies, reduces recurrences by 30 to 40%. Most effective intravesical agent. Patients who, in fact, progress or recur on BCG, in fact, require a cystectomy. That's not the option that we have. Then, what is the problem? The problem is about the dose. There are different strains of BCG available. BCG, in fact, is a vaccine, so the dosage is in the terms of colony forming units, that is CFU, and not milligrams. Various strains are available across the world. These strains are available in different mg vials, but they all contain the same amount of colony forming units. The recommended dose is 10 raised to 8 to 10 raised to 9 colony forming units per instillation. Worldwide, this dose is available in one vial, which may be of different mgs depending upon the strain. Now, in India, we used the Danish 151 strain in 2016, and we used 120 mg. We used 3 vials. In 2016, we shifted to Moscow strain because Danish became unavailable. We continued to use 120 mg. We installed 3 vials. No dose finding study was done prior to introduction of the new strain. We have been installing 3 times the required CSU in every installation. And this is such a big problem. The magnitude of the problem. So the toxicity with BCG comes that more than 50% of patients have moderate to severe LUTs, that is urinary tract symptoms, leading to a discontinuation rate in more than 40% patients. 7 to 15% patients actually need anti-cox therapy if they have systemic effects. 3 to 10% patients need a cystectomy just because they have severe LUTs and not because they have impact disease recurrence. So we at Tata Memorial Hospital have shifted from 120 mg to 80 mg since the last 3 years. Now, if it is such a big problem, has it not been looked at before? It has, and we tried to gauge what is the practice in our urology community. We sent out this review. We got this questionnaire. We got 97 responses, and various cases of doses of BCG are being used across the country. We asked them if toxicity is a matter of concern, and a lot of responders said that toxicity was a matter of concern. And around 31% of responders said that only less than 50% of their patients are able to complete maintenance therapy with BCG. With this background, we in fact written to the Indian Journal of Urology that we need an urgent review of the dose of BCG that we are using in the country. This is currently in the peer review. Now, the previous studies in Indian population that have looked at BCG dose reduction have in fact said that non-inferior recurrence rates are seen with doses less than 120 mg. However, these were done with the Danish 131 strain, which is not available correctly, and they did not follow the recommended installation schedule, and hence their results are not widely accepted. No study has previously looked at de-escalating the dose of intravesical BCG with the currently available Moscow strain with the recommended swap installation schedule. So we are hypothesizing that there exists a reduced dose of the Moscow strain which maintains the oncological efficacy, and this allows for a reduction in the side effects. Our primary objective is to arrive at that lowest possible effective dose without compromising the oncological efficacy. And our endpoint would be when we arrive at that dose, the lowest possible effective dose. Our secondary objectives would be to compare the toxicity of the various doses using validated questionnaires. We would also then validate these questionnaires in our regional languages. We would look at the percentages of patients who can actually complete the induction and maintenance therapies with the various doses. We would grade the cystoscopic appearance of BCG-induced cystitis, and we would assess what cost impact it has to the patients if a lower dose is found to be more effective. The primary outcome we are looking at is oncological efficacy. The actual measurement would require to follow patients for recurrence and progression, which would be too long, and hence to specifically use a surrogate marker in the form of urinary cytokines. BCG is an immunotherapeutic agent which leads to a change in urinary cytokine levels, and these have been immediately shown to be predictive of disease recurrence. What we're going to use in this study is this nomogram, which looks at the change in the level of urinary cytokines, 9 urinary cytokines, before and after BCG installation. And as you can see at the bottom of the figure, it's the probability of recurrence for each particular patient. Now, this nomogram has an accuracy of predicting clinical outcomes at an accuracy of 85.5%. Now, we know that with the Moscow strain in India, we have a 2-year recurrence-free survival of 72%. So, this translates to a per patient recurrence probability of 0.3. For a group of 10 patients, we would aim that 7 patients would be recurrence-free at 2 years. So, we have designed this dose de-escalation study and a dose will be considered to be oncologically equivalent to the immediately higher dose if the probability of recurrence as estimated by the nomogram is only up to 0.3 for 7 or more patients in that group of 10 patients who are receiving that dose. Our eligible patients would be any patient with non-muscle invasive bladder cancer whose plan for intravasacular BCG therapy has decent performance status. We would exclude any patient who should receive BCG therapy but has different contraindications to receive BCG therapy or has any other variant of bladder cancer like a non-invasive bladder cancer. So, a trans-urethral section of bladder tumor would be performed. Patients would be graded as intermediate or high risk and they would be planned for BCG therapy. We would recruit first 2 groups of 10 patients, give to the first 10 patients 80 mg, which is the dose that we use currently. If the next 10 patients, 60 mg. At the first installation, we would collect urine samples for measuring the cytokine levels at baseline and also estimate the baseline quality of life in the questionnaires. We will complete the 6 weekly installations, that is 1 installation per week for 6 weeks. At the 6th installation, we would collect urine samples immediately and after 4 hours and see how they compare with the baseline, and also measure change in the lux and the quality of life. We would then determine if this 60 mg is oncologically equivalent to 80 mg using the hypothesis that we just said. If found to be equivalent, we then recruit the next group of patients for the 40 mg dose and repeat this whole cycle. And if not, if the 60 mg is not oncologically equivalent, we end the study there. What implications does this have? The magnitude of impact. We are looking at 20,000 new cases of bladder cancer in India per year, out of which 14,000 per year receive BCG therapy.
1 minute left.
So if a lower dose of BCG is actually found to be oncologically non-inferior, we would have reduced side effects and improved quality of life. The patient would not be spending as much as he does right now for the BCG virus. And also we prescribe a lot of supporting medications to our patients to take care of the side effects. Even that would not be required because side effects are going on. India is the largest market for the Moscow strain in the world. And there is a definite global shortage as of now today for BCG because the different strains outside are not really available. If lesser number of vials are required per patient in India, we could potentially be looking at exporting these vials outside and have solve the problem of global BCG shortage. This could be an indirect global implication of reducing the BCG dose for our Indian patients. Thank you so much.